As you can see from the map, there are countries, particularly sub-Saharan Africa, which is the place I'm pointing, that are actually facing the brunt of these maternal mortalities. It means there are over 500 maternal mortality cases that happen in this part of the world, which is sub-Saharan Africa, per 100,000 live births, which is a big thing, that really requires attention. So what do we have to do? One of the key things is that maternal mortality is a big challenge, like I've shown you on the map, and a lot needs to be done about it. And one other thing that I really appreciate is that a lot has actually been done, and since a lot has been done, we are still facing significant challenges. And one bad thing about it is that every 2 minutes globally, there is a mother dying of pregnancy-related complications, and the pregnancy-related complications are from things that are preventable, which is a bad thing. And I wouldn't imagine that anyone amongst us would want to be that mother. So the preventable causes, of course, are things that as nurses we are able to actually cover and really work on and ensure that they don't happen. Things such as hemorrhage, obstetric labor, unsafe abortion. These are things that actually can be controlled. So what are governments doing? Several governments are putting in strategies to help reduce this challenge, and my government, Kenya, as you've heard from presenters who are here before and in the morning, I've put in one of the key things we call a free delivery policy, which is currently running throughout the country, and it tends to address the maternal mortality gaps that are actually there. So why Kenya, and why is it that Kenya has this gap? So I'll give you just some brief justification on why this is important. One of the key things that WHO mentioned is that Kenya is one of the countries that has highest maternal deaths in the world, and it is something that has been on the news for quite some time now, which is very alarming, but definitely we are doing something with it. And being that the government has rolled a program called the Free Maternity Program, we still have significant challenges that we need to address. And what are these challenges? Being that it is free and hospitals are being reimbursed for this, for providing care, we notice that the rates of cesarean section births have actually gone up since the government reimburses facilities for providing this care. So in ways that we can't explain, hospitals are preferring to provide cesarean sections than normal births, even in areas that they are not required. And the reason for this is here. The reason for this is because hospitals are reimbursed as high as 30,000 Kenya shillings, which is approximately $300 to provide a single cesarean section. So they take advantage of that. Yeah? In economics, we call it moral hazard. And in Kenya, deaths from cesarean section have definitely gone up, which is something that has also been on news. And the sad bit is that for those who live here, there was a mother who has been on news for a very long time. Her name is Evelyn. Evelyn died a couple of months ago. Sad that we have to use this as an example. She gave birth to quintuplets. 2 of them died, some survived, but it was as a result of just after having cesarean section, or basically just after giving birth. So many different counties, because you know there are many counties in Kenya, are putting up programs to alleviate these maternal mortalities, which is on top of what the government is doing. Part of the counties are in the northern sphere, which bears the brunt of the huge brunt of maternal mortalities, particularly in Kenya. They've put up programs aside from the free maternity, which the national government do to fight the maternal deaths. However, some counties are still experiencing challenges. One significant one is Kiambu, which is a place where we conducted or are conducting this study because it's an ongoing study, where hospitals are still being closed down or they are facing challenges, particularly for mothers that are coming to give birth. This is something definitely we know that should not be happening in the current setting, being that we are targeting to achieve universal healthcare coverage. Having given you that background, as we heard in the morning, one of the key things that our president is trying to achieve is the Big Four agenda, and the key part of the Big Four agenda is achieving universal healthcare coverage, for which this free maternal policy is part. One thing that people tend to confuse about universal coverage is they only think of it as increasing coverage, but then they forget the element of quality and preventing people from having unnecessary health expenditures. So I just want to give a brief and just say that universal health coverage, aside from just increasing the coverage in itself, which is the number of people who are meant to access care, we are actually meant to provide quality care and definitely alleviate poverty or impoverishment, for those of you who think about it in economics terms. Having said that, so what did we do? We conducted a case study, and the case study was conducted in one of the counties, which is Kiambu. Kiambu was purposefully selected because of the challenges that they've been facing, particularly in managing healthcare. Kiambu is one of the counties that's significantly closer to Nairobi, which is a city center. Fairly, I would put it at the top of the cream as fairly rich a county, but then they still face the challenges. So we wanted to dig deeper using a case study and understand what is it that happens and why do they still face such kind of significant issues on maternal issues. And this case study was in 3 hospitals. So a level 3 hospital, which is a lower level hospital that doesn't provide surgery per se, but it's the most basic level of care that you'd expect anybody within the community would first go to. The best part about this level of hospital is that they provide just normal deliveries and other significant maternal care. The other part was in medium level hospital, which is a semi-referral hospital. We also wanted to understand the dynamics that these kind of hospitals do, but then I also did the study in a referral hospital. So there were 3 levels of hospitals that we were trying to compare and understand what's the difference in maternal care that are provided in this, particularly on the aspect of free delivery that the government is doing. We applied a range of mixed methods. Some are still ongoing, and the ongoing ones are basically using econometrics method to understand the changes. But the ones that we've used for this presentation are basically a systematic document review that definitely has followed the Prisma way of presenting result. And we have in-depth interviews that we did with the mothers and the hospital facility managers, who are either the nurses and the doctors who provide the care. We wanted to understand what's their perception, particularly on quality and things like that. A significant thing that we also did was to do a patient exit interview. It's difficult to measure perception. And one of the key things about quality perception that we do is just to ask the mothers when they exit the hospital after delivering, ask them whether they were satisfied with the services, and we have a range of questions, up to 23 indicators that we were using. And the unit of analysis, being that it's a case study, is the quality of care. The framework that guided our study basically for all those mixed methods approach is the WHO framework, and the WHO framework focuses on all the 3 components of Donner-Bedinan quality framework: the structure, which is the hospital, healthcare workers, and people like that. Then we have the processes, which is what do healthcare workers actually provide, and it can be divided in 2 forms: provision of care and the experience of care. What do the patients, who in this case are the mothers, what do they perceive? What do they perceive of the healthcare workers and things like that? And how are referral things organized? What's the emotional support and things that they face? But we also wanted to understand the outcome. The outcome in this case would be maternal deaths, stillbirths, live births, and things like that. Just quickly to run you through results, our results showed that Kenya is not just the first country to implement free maternal policy. Actually, globally, there are many countries that are experiencing free maternity. And one of the key things that is very common with this map you see here is we used GIS to really map the countries that are doing this, and we noticed that many countries are actually doing free maternity policies from different angles. Some are providing free cesarean sections, some are providing subsidized care where the patients also pay something, but some are entirely free, where the patient is just meant to go to the hospital, provide the care, get the care, then walk home. Then the government takes care of the rest. So this is just to give you an highlight that Kenya is basically not the first country to have done this. So what did we find out in terms of the quality results that we are looking at? I've just done them thematically, and in the 3 hospitals that we noticed that the healthcare workers are actually motivated differently. So I'll give you a scenario. As in economics, if you provide free care, you'd expect that the numbers of people who access the care goes higher, which is the same case we found here. So the numbers of mothers who are accessing care, who probably previously were going to traditional birth attendants or were not giving birth in the hospitals, are now giving birth in the hospitals. And what's the ripple effect of this? If the numbers are going higher and the numbers of healthcare workers it's the same, it means the healthcare workers will be overwhelmed with provision of services. And if they're overwhelmed with provision of services, then what happens? Some of them have higher workload, and we still face significant challenges such as shortage of the workers. But one key thing that I really appreciate that we found out here is that from the in-depth interviews that we had with the healthcare workers and some of the patients, they actually appreciate the work the nurses are doing. While they say that the nurses are having a lot of workload to provide the care, they actually appreciate, and they say that they go way beyond their abilities to make sure that they are given better quality, which is a key thing that we have to appreciate and take, despite the fact that there are these shortages. Another significant thing that we found out was that there are issues with physical conditions of the hospital, which definitely do not change. We have bad indicators of quality, such as omission, like if you go to places where they need to monitor pathographs, there are challenges with that, which is something we took cognizant of the fact. And then there is an element of respect that is deteriorating, and as healthcare workers, we definitely need to do something about it. Having said that, just in conclusion, then what is it that we can do to ensure that there is universal healthcare coverage 100% with this free maternal policy? We need to do an inclusive participation of people in design, where we put everybody together and ensure that they are aware of what the policy, which is free, entails, and we need to communicate this effectively to other people, even the people on the ground, and the people who are actually doing the actual work. Uniformity of service is important. It doesn't hurt. I mean, it hurts if one center provides care better than another center, yet they are meant to be uniform and the same. And then we need to put quality guidelines and actually monitor the system as they work to ensure that we achieve 100% universal coverage. And again, this is work that is ongoing, and we'll be looking forward to presenting even other results. But I just want to appreciate for this, and that's the end of our presentation. Thank you for listening.